There's unequal jaw growth, and basically the side where the jaw has grown less is the side that's affected. Children with TMJ enrollment should have an orthodontic examination regularly. I don't know if you can tell, but the toes are not the same length here. This child is obese because he was on high dose of steroids for several years. He was on Hakim medication, and then he would switch from Hakim to main steroid. And if you can tell from here, this child is a systemic juvenile arthritis. He's on 20 milligrams of methotrexate. He's on steroids. He's still not happy. He's severely growth retarded. He's about 10 years old. He looks 6. It's another child with leg-length discrepancy. This child I took from the ACR connection. Uveitis, anterior uveitis. I don't know if you can see the hypoplane. Uveitis is a serious problem, especially in post-articular. Children must be examined with a slit lamp, minimum 6 months, and if they are early positive and less than 6 to 7 years of age, at least thrice a year. How do you treat uveitis? And please let me emphasize, this uveitis is asymptomatic. The child will not have any complaints unless and until we screen them. We are going to miss them, and it is a very serious and causes a lot of issues: cataract, band keratopathy, and blindness as well. If children don't respond to topical things like glucocorticoids and nutriatics, then you can try systemic DMARDs. Methotrexate has worked well, cyclosporin, mycophenolate. Infliximab actually does better in children with uveitis, so uveitis and etanercept. Just briefly about macrophage activation syndrome. In systemic arthritis, if practicing systemic arthritis, we don't know why it occurs in many cases. Sometimes we may get a history of fever or an infection, or we may have it may occur secondary to surgery, anti-inflammatory, especially aspirin was notorious for that, sulfasalazine, gold, but many times we don't know why it happens. And in systemic arthritis, your counts are usually high, so you have a high TLC, you have some thrombocytosis. If they suddenly begin to drop, and you see chemically ecchymosis bruising, please watch out, because probably this child has developed mass. How do you treat it? Number 1, please withdraw all NSAIDs, other treatments. The only thing you should leave them on is steroids and cyclosporin, fresh frozen plasma, IV or parenteral corticosteroids should be given. We need to give them supportive care. Cyclosporin does work very well sometimes. Anti-TNF might help. IVIG, there is anecdotal evidence. In some series it has done well, and some it hasn't. Stem cell transplant, people have done work on it, but it is very expensive, and of course it has a lot of morbidity with it. PC, osteoporosis in children. Please don't diagnose osteoporosis in children just because they have a BMD score, and especially if it's been reported with a T-score. Children should have the Z-scores done on the pediatric software, and they should have a clinical history of fragility fracture before you can say that they have osteoporosis. Don't rush into treatment, don't put them on the phosphonates unless and until they have fractured. What do you do with them? A lot of osteoporosis, childhood osteoporosis actually relates after puberty. If you can maintain adequate exercise, give them lots of calcium and vitamin D, they might be okay. But if they are fractured, of course, then you have to think about bisphosphonates. IV pomegranate, you have the most experience with this. Alendronate has now been used, and growth hormone is being used as well. Joint replacement, what about joint replacement? If a child has totally destroyed his joint at any age, you can get it replaced. There is a concern what will happen to the growth, etc. If the joint is destroyed, it's not going to grow anyway. And if it's severely limiting the quality of the child's life, please have it changed. Additionally, just want to mention the micronatia that may happen in some children. You can actually repair that, but you have to wait, obviously, till the facial bones are fully developed. I'd like to emphasize again, radiographic changes in polyarticular systemics begin to occur at 22 months. We need to catch them before that. Many parents and physicians voice fear of funding side effects from medication. They can't compare with the side effects or the effects of this disease. I am just going to quote a patient, actually one of my juvenile arthritis patients came to see me just before I was coming, and I said, I'm giving a talk, and I'm going to show you pictures, and do you want to say anything? And I'm quoting, this is a maybe, it's a share actually, that we have hope for it. And I was really heartbroken to hear that. She was 9, nobody picked her up, nobody diagnosed her. She was 24 when I saw her. Just look at her. Please don't let this happen. It can be treated. This girl came in, she's on treatment, she's doing very well. Thank you so much. If I have just 1 minute, can I just briefly thank a few people who helped me so much in my passion for doing pediatric rheumatology. I think I'd like to thank Dr. Nikhat, who taught me how to treat my post-juvenile arthritis patient. Professor Sarah Walker is sitting here, who facilitated my going to Kansas, and training with Dr. Karen Lindsay, which was wonderful. And Prudence Manners, who conducted the fabulous course that I was able to take. Last but not least, Ahmed Said, who was always there for me. Thank you so much.